In here we can have orbital inflammatory disease can be divided into idiopathic or secondary, and then idiopathic is in the inflammatory pseudotumor or non-specific orbital inflammation. And for the secondary, we have a systemic inflammatory disease divided to grave orbitopathy, and then granulomatous with polyrhinitis, and then for the secondary we can have related foreign body also, and then infection disease. And we know the orbital inflammatory pseudotumor in our place, we call it only pseudotumor, but it's some can say that it's a non-specific orbital inflammation or idiopathic orbital inflammation or orbital inflammatory syndrome. And the most common case with painful orbitopathy, I think, in adults is more common in our hospital is pseudotumor. And the sign is a benign inflammatory process with the orbit characterized by the polymorphous lymphoid infiltrate inferring degree and fibrosis without as known a local and a specific cause. And I think for the pseudotumor or idiopathic non-specific orbital inflammation, I think it's very responsive with the steroid. This is our case. Within maybe 48 hours, we can see about the improvement of the sign of the inflammation after we give the systemic prednisolone or methylprednisolone. And 5% of the pseudotumor, I think the recurrency is common. I think it's very trouble with our case if they have recurrency during the treatment. And etiology is still unknown, maybe caused by inflammatory autoimmune, and then IgG for related or immune-mediated process. And there is so many types. There is myositis, we can divide it into grave orbitopathy, and choroiditis, anterior, posterior, or diffuse type. And in the clinical featuring and imaging, usually came to us with the proptosis, unilateral or bilateral. And in myositis type, usually they get diplopia, pain in exacerbate with eye movement and enlargement of the rectus muscle with tendon involvement, I think, in the CT scan. And in the choroiditis type, usually in the superotemporal eyelid and conjunctiva swelling, there is a pain, tendon mass in the lacrimal gland area and enlargement of the lacrimal gland in the CT scan. Like in here, we can see the sign and, from the CT scan and the clinical picture. And from the anterior type, of course, there's plain eyelid edema, conjunctival chemosis, and then limitation of ocular motility and ill-defined mass in the CT scan. And posterior, severe pain with visual loss, motility of disturbance, less than the anterior segment inflammation because this is in a posterior type, and if it's ill-defined mass in orbital apex, and sometimes usually there is a compress of nerve and muscle. And for the clinical imaging, of course, in diffuse, there's pain, edema, conjunctival phimosis, and limitation motility more severe than the other type. And sometimes we can see in another imaging that there was any corridor thickening and then retinal detachment. And of course, the management for the pseudotumor or non-specific orbital inflammation is a high-dose steroid followed by tapering of this medicine and until the minimize adverse effect and preserve the disease control. We use usually in methylprednisolone with 0.5 milligram per kilogram body weight, and then for maximal dose is 80 milligram per day. Or we can use it pulse IV steroid with maximal dose is 1,000 milligram a day. And for another kind of management, of course, we can use the radiotherapy, sclerotactic, external beam, and surgical therapy, or we can use the combined therapy. There's any medicine that can be used for the pseudotumor, like cytotoxic agent, immunosuppressive, immunoglobulin, immunosuppression agent like methotrexate, cyclosporine, azathioprine, and then TNF inhibitor and mycophenolate mofetil. And there is another kind of monoclonal antibody. But I didn't use this kind of medicine yet. This is, for example, with case with the myositis type. In here we can see there is enlargement of the muscle. Usually in here we can see in the temporal side not only the proptosis, swelling of the eyelid, and chemosis. And for the non-specific orbital inflammation in lacrimal type, usually in the superior temporal, we can see the mass and the CT scan and the superior temporal region. Usually the eye is not so inflamed, but surrounding the lacrimal region there is edema and brightness and swelling. But the patient usually complain with the pain in the movement. Another kind, our diagnosis differential for the inflammation like this is thyroid disease, but we know the thyroid disease is common in the hormone and associated with the hyperthyroid and smoking. Even yesterday we can see not all the smoking with the history got grave orbitopathy. And for the clinical picture, I think for the grave orbitopathy is very pathognomonic, but some of them doesn't have a specific clinical feature. But usually they have proptosis, eye retraction is most common for the grave orbitopathy, and that there is lid lag, diplopia, lagophthalmus, and sometimes it may be unsymmetric. The eyelid edema, conjunctival hyperemia, and exposure